Okay, I think we should commence. Once again, friends and colleagues, good evening to all of you. On behalf of the European Respiratory Society and the Pan-African Thoracic Society, and together with my co-chair, Dr. Isme de Kleer, I'd like to extend a warm welcome to, firstly, our two eminent speakers, both established researchers in their fields, as well as all the attendees to this webinar. So without doubt, almost all of us are here because we fully appreciate the consequences of air pollution on lung health. And their studies have repeatedly shown the effects of air pollution at different points in the life cycle and at levels of exposure below that of international standards. Our two speakers intend to explore this topic and provide us with cogent arguments and interventions to address the issue. Essentially, the format of the webinar is going to be that our two presentations will take place by the two speakers, 20 minutes each, and this will be followed by a question and answer session. We are asking participants to please enter their questions into the Q&A facility on the Zoom platform. And at the end of both the presentations, the co-chairs will read out the questions to the speakers, and then we will follow this with the discussions. With that, I'd like to introduce you to our first speaker, Dr. Jakob Usemann. Dr. Usemann is a medical doctor who was born in Hamburg, northern Germany. And after his 3 years of clinical training at the Charité University Hospital in Berlin, he moved to Basel, Switzerland for his PhD in epidemiology in the research group under Prof. Urs Frey. During his PhD, he studied risk factors for lung development, focusing on environmental exposures. Currently, Dr. Usemann is working as a clinical scientist. He's working as a pediatric pulmonologist at the University Children's Hospital of Zurich and Basel in Switzerland. And he pursues research on the risk factors impacting on lung development in children. Dr. Usemann, firstly, many thanks for kindly agreeing to share your research findings with us. And I now invite you to present your talk. Thank you. Jakob, you're still muted.
Okay, sorry. Now you could hear me. Is that correct?
Yes, we can, and we can see your presentation.
Perfect. Thank you again. Thank you very much for this kind introduction and a warm welcome from Switzerland. It's an honor for me to speak here for the European Respiratory Society and the Pan-African Thoracic Society. And during my talk, I would like to share some of my research and from other groups around the world on the impact of air pollution on lung development in children. To give you a brief overview over my talk, I will start with a very short introduction about pollutants, about outdoor and indoor pollutants. Then I will focus on air pollution and the impact on early lung development, especially focusing on exposure during pregnancy. Then I will talk a little bit about air pollution in the developing lung in children, so more focusing on long-term development. So to give you a short overview, the outdoor pollutants which are relevant is very important is particulate matter. It's differentiated by its size, and it's measured in micrometers. And we can see that the smaller the diameter is, the more deep it enters into the lung. Other important pollutants is carbon monoxide, CO, sulfur dioxide, also nitrogen dioxide, very important, and ozone, as well as polycyclic aromatic hydrocarbons. When we talk about tobacco, indoor air pollution, a still very relevant source is tobacco smoking, but also biomass from burning and cooking in the house, as well as open fireplaces, and also some materials in the house. To give you a short impression about the size, which I was talking about the particulate matter, on the right-hand side, you see a hair. Sorry, I will just change my... Oops, to a pointer. So here we have a hair. You see the high size of the hair, and we see here how small these particles actually are. PM2.5 here shown exemplary with a diameter below 2.5 micrometers, and it's very small, so it can deeply enter the lungs. It originates mostly from traffic and industry and has a rather homogeneous spatial distribution. Nitric dioxide, on the other hand, mostly originates from traffic and is therefore also usually closer if you are closer to roads, higher if you're closer to roads. Another important source is black carbon, and it originates mostly from gas and full biomass burning. Here, a short overview again. We have different sources of air pollution. We have the stationary sources in industry. We have mobile sources, cars and airplanes. We have also a relevant source in farming, livestock and fertilizers, and obviously cities. And then we have also, very recently important in the States, fires, so burning fires in the forest, which also contribute to air pollution. These then all contribute to the pollutants which we have in the air. There are certain characteristics of these air pollutants, and there's a special spatial variation in these pollutants. One study I would like to point out done in the Netherlands, where you can see here on the lower panel PM10, and you see the spatial variation with small peaks. And as I mentioned already for the NO2, we have more variation indicated here by these tighter peaks in this timeline. A very recent study on the right-hand side was done in South Africa, where also the PM10 concentration was assessed. And you see here on the left-hand side a map. And the redder the area, the higher the concentration is. And importantly, was pointed out already here, and that these pollutants exceed the WHO cutoffs for PM10. Also very important is here on the right-hand side shown, that's the distribution of the wind. So the wind has a different, has a very important impact how these air pollutants actually concentrate in the air. So if you have a blowing wind, they normally blow the pollutants away. However, if there's no wind, the pollutants accumulate more. Also important is the temporal variation in these exposures. This is exemplary shown here in Switzerland. On the left-hand side, we have PM2.5 concentration, and it is measured over the last 30 years. And we have a decrease in the PM2 concentration over the last 30 years, almost by 50%. And this is similarly shown for NO2, where we have also about 1/3 a decrease in the NO2 concentration. A very recent study done in South Africa, very interesting. They looked at factors which actually decreased the NO2 variation. And I will start first here on the right-hand side. You see a map here. And on the left side, you see the color scale. And the bluer the color is, the higher the decrease in NO2 is. And you see here, especially in southern areas of South Africa here, that we have a relevant decrease in NO2. So the air was actually getting better in the last 12 years. This is when the study period was. And importantly, they linked this to the change in burning area, and they also observed that actually the burning in this area decreased. So there seems to be a link between fewer burning areas in this land use and also decrease in NO2. So I would say a little bit of a positive sign we can observe here. Now, what are the mechanisms during pregnancy and lung development? So the impact on lung development is obviously dependent on the stage of development, and there are different effects on the mother. So air pollutants can reduce the placental perfusion. It also can negatively impact the nutrition transferred to the fetus, and it may also have a direct toxic effect through placental transfer of pollutants, so a direct impact through nanoparticles. On the other hand, we have also pro-inflammatory and oxidative stress, and this is, for example, shown on changes in the immune system after air pollution exposure in newborns, but also on lung growth and development, and also recently proposed there are also genetic and epigenetic effects. This is here again summarized in a figure. So we have a systemic inflammation in the mother, and this negatively then impacts on the placenta and the fetus. There's also endothelial dysfunction and oxidative stress, with further impacts negatively on the nutritions which are transferred to the fetus. And as I pointed out already, there's also a direct effect of these pollutants. And this has been very nice reviewed in the paper here in 2017, published from our group, but also by a lot of other groups. Now, this is again a figure showing the development. I would like to point out here why this prenatal phase is so important. So this is adapted from a very old paper already, but we see here the lung growth during development and the maximum lung volume which can be reached, which then decreases obviously over time. However, if we have a prenatal exposure, the maximum attained lung function cannot be reached anymore, and we have the decline in lung function earlier, so patients become earlier symptomatic if during the early phase the damage occurs already. And the early lung function now has been assessed in different studies. This is a study done by our group more than 10 years ago. It is conducted in the BUILD study, which is the Basel-Bern infant lung development cohort, a cohort where I was also doing my PhD in. And in this study, several years ago already, more than 200 infants were recruited. And this was a healthy birth cohort, and they received a lung function test at approximately 5 weeks of postmenstrual age. And the important thing is that lung function was done without any sedation. And what you can see here, this is from tidal breathing parameters, that the minute ventilation increased due to higher PM10 exposure. So there's an impact on breathing, and also a marker for airway inflammation, the exhaled nitric oxide, which we also assessed in the airways, also increased here after higher levels of PM10. And this has been robust after several adjustments. Very similarly, just recently published a study from the Krakenstein Child Health Study, a kind of similar setup, also lung function done at 5 weeks of age, but also at 1 year of age, which we did not do in Switzerland. And this is very interesting data confirming what we've seen several years ago. They saw also that the PM10 exposure had an impact on FRC, a parameter which we did not see an effect on, but they also saw that the postnatal exposure also negatively impacts lung development, indicated here by a lower tidal volume due to higher PM10 levels. Now, when we look at the later phase of development, a study done in Spain looked at lung function at approximately 5 years of age, and they had a pretty large sample, and they investigated especially the second trimester during pregnancy. And what you can see on the left side, the decrease in FEV1 measured at approximately 5 years of age, which I mentioned, and there's obviously a clear trend of decrease in FEV1 with higher benzene concentration. And similarly here on the right-hand side, the same can be seen with higher NO2 levels. So obviously a clear impact. Now I will focus more on the long-term effects. And just to summarize shortly, I pointed out already that there is a clear impact on early lung function, but this has also been shown in children where reduced lung function has been shown after higher air pollution levels. This has also been reported for other pulmonary outcomes such as bronchitis, chronic cough, and also a little bit for asthma. For ozone, data is a little bit controversial. However, also some studies have shown a decline in lung function after higher ozone levels, and consistently shown road traffic, especially NO2, is correlated with hay fever and also other allergic outcomes. Now, what is the impact on longitudinal lung development? Several studies has assessed it in different parts of the world. The study in Poland has observed a clear association between higher air pollution and reduced lung development. And also this has been shown in other studies focusing specifically on PM10. And very interesting is also that children who actually move away from polluted areas, they can actually then return to normal functional development if they are living in cleaner areas. And also very important is that this has been shown for respiratory symptoms where a higher air quality was actually related to reduced clinical symptoms. Now, why is this long-term development so important? This is what we call tracking of lung function, which I pointed out already before, that the early impact has a long-term impact. The early impact during the prenatal phase or the early years has a long-term impact. And this has been shown in a study several years ago from Stern and colleagues. So they did lung function in infants already with a thoracic compression technique. So they could actually measure airway obstruction in infants already, kind of invasive, but interesting parameter because it can be directly compared to FEV1. And what they saw that those infants with a lower FEV1 at birth, they also have a lower FEV1 at later ages, 10, 16 years, and also 22 years. So there's a clear tracking. And what I also would like to point out that this tracking is also influenced by other risk factors. And this has been shown in a longitudinal study where those children with breathing disorders actually have a higher decline in lung function. So in the end, ending up here with the lowest FEV1 value compared to those who do not wheeze. So obviously there are different risk factors involved how this tracking of lung function occurs. In regards to environmental exposure on this tracking of lung function, this has been very well summarized recently. And we hear the combination of different risk factors. And I would just like to point out and focus on this red line where they assess the combination of different risk factors, meaning indoor air pollution, so the mother smoked during pregnancy, and also environmental exposures. And these were actually the children who then over life had the lowest lung function during the development phase. Also interesting, what I found that actually the season of birth also has an impact, as well as the age of the mother, which is both negatively associated with lung development. Now, this is a study which we published recently, and what we observed here during the assessment of air pollutants, that air pollution actually decreases in Switzerland. So this is, in a way, I would say, a good message. We have less air pollutants. However, if you look at the WHO cutoff, you see there are still some infants which are exposed to higher air pollution. And we see here on the Y line, the timeline of our study. So we assessed air pollution from pregnancy on until follow-up, which was at 6 years of age. And at this time, we then performed lung function. So we have a decrease in air pollution, and we could assess this over the longitudinal study design. What we did then is we pooled the groups which had the highest air pollution together, and this is the red line. And what we observed that those children with the higher air pollution in pregnancy actually have a lower FEV1 at school age. However, this has only been observed for the highest exposed group, but I would like to point out here that these children actually had a very low air pollution exposure and still had a significant decrease in lung function at 6 years of age, which indicates already that the WHO cutoff for air pollutants is something we maybe want to discuss later. So obviously this data consistently showed that also low exposure levels have a negative impact already on air pollution on lung development. So to summarize these findings, which I just showed you, we have several risk factors involved in lung development. This is outdoor and indoor air pollution, but also other risk factors such as asthma or wheezing disorders. And all these different risk factors may all have a small contribution, but the combination of those actually contribute to the decline in lung function over time and impacts when children or then adults and older people become symptomatic. Now, during the last minutes of my talk, I would now like to focus on indoor air pollution. And this is a study describing the use of solid fuel use over the whole world. And the redder the areas is here in Africa, but it also in a lot of parts of Asia, you see that solid fuel use is still highly used. Another study looked now what kind of concentration you actually get indoor when you cook with what kind of wood or animal dung you use, and they measured the PM2.5 values. And what you can see here on the y-axis, the different uses of cooking, and on the y-axis here, sorry, you have the PM2.5 concentration. And you see here the numbers, and you see it's a very high concentration we get when, for example, wood is used. And if you consider what the WHO recommends, all these different cooking modalities were above the recommended cutoff from the WHO. For Switzerland, just to compare, the indoor air pollution is around 12, where normally these cookings are not so much used, a lot of electric and gas cooking, but we see here that in a lot of parts of the world, this is a big problem for indoor air pollution. Regarding this indoor air pollution, several outcomes have been assessed. There's clear evidence that this increases the risk for asthma, and this has been nicely summarized here in a review recently published in the ERJ. And I would finalize my talk with a very interesting study done in different parts of Guatemala. And this was a study, intervention study actually, where almost 500 families were recruited. And the intervention was that they had a chimney installed. And this is, you see here, a kitchen where the intervention was done. And this was the original cooking setting. So the group 1 was the group where the intervention was done. So at birth already, these families received such a nice kitchen in their home. However, the others, group 2 and 3, they got this kitchen later with 18 months of age when the child was 18 months old. And then they all these groups received spirometry between 5 and 8 years. And what you see here in the results table, the group 1 is obviously the reference group because this was the intervention group. And compared to this group who received the clean kitchen already at birth, we see here that the other groups have a decrease in FEV1 by about 50 milliliters and also an FEC when the kitchen was installed later with 18 months. So I think this study nicely shows that this early phase of lung development, pregnancy, first year of life, is a very sensitive period. And when intervention measures are done very early, this can have a relevant impact on lung development. So I would like to conclude my talk here with some messages for you. So I think there's a clear association between exposure towards air pollution and impaired lung development, and this has been shown in a lot of studies. There also seems to be a stronger effect during the early phase of lung development when we have the fastest lung growth. And what has also been shown that the reduction of exposure may be even associated with improved lung growth. And what we also see that exposure below WHO cutoffs may still have a negative impact on lung function and lung development. And even though air pollution is, I think, a very relevant source, there are obviously different sources which in their combination have a negative impact. So these modifiable risk factors, I think, therefore, should be reduced in the future. And I would like to end my talk here with the questions, with what thresholds for air pollution do we need in the future? And maybe we can come to that in the end of the discussion and see what kind of ideas come from you guys and from the audience. And with that, I very much thank my two mentors. It's Professor Frey in Basel and Professor Latzin in Bern, and Mr. Kies and Professor Rösli, who are doing the air pollution modeling in Switzerland, and we have a very good collaboration with. And with that, I thank you very much for your attention and would like to end my talk here with the view of our hospital. Thank you very much.
Jakob, thank you very much for that very interesting talk and for being able to very succinctly put down all the key issues around this very complex topic in a short space of time. Thank you very much for that. We're not going to take any questions now, but I would like to encourage the participants to please post your questions on the Q&A facility on the Zoom platform, and we will address your questions at the end of the second talk. I'd now like to hand over to my co-chair, Isme, for introducing the next speaker. Thank you very much.
Good evening, all. I would like to introduce the next speaker then. That is Dr. Rebecca Nantanda. Dr. Rebecca Nantanda is a senior research fellow at Makerere University Lung Institute in Uganda and a postdoctoral research associate at Liverpool School of Medicine in the UK. She's involved in research projects on lung health in children, and she's clinically active and involved in training and research supervision of graduate students. Dr. Nantanda is the co-chair of the Asthma Management Working Group of the International Union Against Tuberculosis and Lung Diseases and founding member of the African Infant and Preschool Lung Function Working Group. Dr. Rebecca Nantanda, the floor is yours. Curious for your presentation.
Thank you so much for the kind introduction. I'll now go straight to share some information around the interventions that have been tried to reduce air pollution exposure in children. So first, I want to remind us about the common sources of air pollution for children. either during pregnancy when your mother is busy working in the kitchen, or when you're a little older, still your mother is cooking, you're exposed to the air pollution. When you start going to school and you don't have a good source of lighting, you may be using, for example, this boy using a candle, and therefore that's a source of air pollution. Or if you're moving to school, to and from school, or depending on where you live, it may be from the industries or the cars, or sometimes in Africa, you're working with your father or mother in the fields, and therefore you get exposed to the air pollution. But first, before I go to the interventions, I want to share why we should intervene. Number one, air pollution, as has just been described, has lifelong implications, starting from the intrauterine life up to adulthood. It affects the growing lungs and other body parts, and therefore children are really very vulnerable. And as a result, it actually impacts on their overall growth and development, and consequently on their potential as children when they are older, but also as adults. And the other reason why we should intervene is that air pollution is actually directly linked to killer diseases. For example, we know that 50% of pneumonia deaths are actually linked to air pollution. So when we try to prevent the air pollution, we are also indirectly preventing these deaths from pneumonia. The good news about prevention is that if you reduce air pollution, then you have improvements in lung function. So how then do we protect children from air pollution? These are really broad thoughts. Number one, we need to invest in sustainable cleaner energy sources. So if you think about interventions, then it should be around cleaner energy sources, reduce on fossil fuel combustion. We should find ways of minimizing children's exposure to polluted air. We should improve air pollution monitoring and its link with children's health. This really helps us when we are trying to look at policies and convincing the policymakers that actually air pollution is affecting the children's lungs. But consequently, overall, we need to strengthen children's overall health so that they have increased resilience to the effects of air pollution. Scholars have proposed how to approach the interventions when you're looking at air pollution in children. Number one, we need, first of all, to reduce the emissions. And once you reduce the emissions, then you have a chance at reducing the concentrations of some of those noxious agents that have been described in the first presentation. And then after that, you have to concentrate on reducing the exposure, and then you can have a chance of actually improving the health of the child. I'll now go into some of the interventions, research that has been done in different parts of the world. And I'll start with the good news, which shows that there is an association of improved air quality with lung development in children. This study was done in Southern California in USA. And in this part of the world, they started air quality monitoring in 1994, but also coincided with a time when they had put certain policies in place to reduce the air quality pollutants within the air, basically the outdoor air pollutants. And what they did in this particular study, it's a study of about over 20 years, and it's basically focusing on children's health, specifically the respiratory health in relation to the air pollution. So they have different cohorts here. They looked at cohort C, D, and E. And what they did was to do some baseline measurements around air pollution and children's lung health and other issues around their health, for example, asthma, respiratory symptoms, and so forth. And then they followed them up until they were about 15 years. So what they did was to annually measure the lung function, and they were looking at how this lung function was actually changing as the air pollution levels were changing. So in the first graph here, you see nitrogen dioxide. This is purely about the air pollution. In 1995, they had high levels, but over time, you see a gradual decline from as high as probably 50% to less than around 10 ppbs. And then when you look at the PM 2.5, it was the same trend from as high as almost 35 micrograms per meter squared down to almost less than 10 over time. And so after realizing this of the children over years, and they noted that actually there was an improvement in the FEV1 over time between the time when they started monitoring the baseline up to the time when the children were about 15 years. The same was noticed when they were looking at PM 2.5. However, in this very study, they didn't notice any change when it was ozone that was looked at or PM 10. But basically, this study showed that if you improve the quality of the air the children breathe, then you have a chance at actually improving their lung function. Then I'll go to some of the interventions that have been tried, especially in Africa and other low-income countries, led by different really players. But I just want to mention that we have the Global Alliance for Clean Cook Stoves, one of the most commonly used interventions in research to try and reduce indoor air pollution. And I'll start with the Respire trial in Guatemala Highlands. In this study, they actually looked at 534 households where there was a pregnant woman or an infant, and they randomized them to receive either the chimney stove, which was described earlier. It had really the chimney such that when the woman would cook, all the smoke would go through the chimney and into the outside environment, or the being in the control group where they continued using the open fires. And their primary outcome was actually looking at the incidence of pneumonia in these children. When they looked at the results, there was no significant reduction in the incidence of physician-diagnosed pneumonia. But when they looked at severe pneumonia per se, there was a significant reduction. So that shows we don't know exactly the reasons why there wasn't a significant reduction in physician-diagnosed pneumonia, but some of the issues were around the consistency in use of the stove stacking, and probably other sources of air pollution within the environment. Then the other big study done in Malawi, really this was a robust, intense study, where again, they were using a cleaner burning biomass fueled cook stove. And the outcome was pneumonia in children less than 5 years. In this particular study, this was a rural area, and they gave each household 2 stoves in the intervention. They gave them a solar panel, and they monitored the personal carbon monoxide on the children. And so after going through for about 18 months, looking at the incidence of pneumonia, again, they did not find any significant difference in the incidence of pneumonia. There was no reduction. It was the same in the control group as well as the intervention group. Just like in the Respire study, there was a significant reduction in the severe pneumonia cases. Another study that I want to share was the one which was done in Rwanda. In this study, again, they used the high efficiency wood burning stove. This was a huge study which was under a particular program where they looked at water for water filters to reduce diarrhea, but also added on the component of looking at the cook stoves to reduce acute respiratory infections. So they looked at 2,174 children, leading to 5,934 AR episodes. And the primary outcome in this study was a caregiver reported acute respiratory infections. Basically, they would go from time to time, every 3 months, to ask the caregiver whether the child had had cough or difficulty in breathing or fast breathing. They also measured personal exposure for the cooks and the children. And what they noted was there was a 25% reduction in the prevalence of acute respiratory infections, which was statistically significant. But this was based on really the caregiver's report. But when they looked at when the community health workers did the diagnosis or when the physicians made the diagnosis, they didn't find any really significant difference between the two groups. What was noted also in this study that there was a gradual decline in stove use from about 85%, 81%, and then there was an increase in traditional stove use to about 20% among those ones who had the intervention. Then, okay, the previous studies that I've described were around clean cook stoves. And so after some of those studies, researchers have mentioned that probably we need to go to the clean fuels. And so there is currently a lot of research which is going around where we are testing LPG. And this one of the study that was done in India, it was a pilot study under the HAPPIN trial. A HAPPIN trial is being done in Rwanda, in Guatemala, in Peru, and India. And basically what they are doing, they are looking at 2 groups in each children. They're looking at the adult women in the households, but they're also looking at the pregnant women and eventually the children to see if if they use LPG, eventually there will be a reduction in the incidences of pneumonia. So this was really a pilot study which they did, trying to find out if it was feasible to do this trial under the particular settings. And they enrolled 41 women, and the criteria was you did not have to have any previous use of LPG, and gestation week between 9 to 20 weeks. And this was a before and after study. So the intervention was that they gave them LPG free of cost. They noted that there was really 100% adherence. And the measurements they did PM 2.5 measurements at personal level, at kitchen level, also at the outdoors. And they did 3 measurements, the baseline at 1 month and 2 months. What they have noted is that there has been a 93% reduction in the mean PM 2.5 when they do the kitchen measurements, but at personal level, it's 78.5. So this gave them an indication that if they go ahead with that trial, probably we are likely to get good results in terms of reduction of the air pollution, which will probably consequently lead to better lung health for the children. Done in Peru. This particular slide, I just want to show what is happening in the older women that they are recruited, not necessarily the pregnant women. And in this study, they are looking at the cardiopulmonary outcomes. So they already started the RCT. They looked at 180 women aged between 25 and 64. And again, the package includes the stove. They deliver the LPG for a period of 1 year. And very important, they have education and behavioral messaging ongoing every time the field workers go to the field to repair any breakdowns and really reinforce the messages. And they assessed the blood pressure, the peak respiratory flow. They looked at the respiratory symptoms using the St. George Respiratory Questionnaire. They also measured PM 2.5 carbon monoxide and black carbon. And they are checking the adherence to the use of the stoves using the temperature loggers. So in this study, the primary outcomes were 2, lung function differences, as well as the respiratory symptoms. What they have seen so far is that despite the 98% use of the LPG, there was no difference in the lung function and respiratory symptoms. So this was in the adults, but I'm wondering what the results are likely to be when it comes to the children. Maybe we'll discuss that a little later. That was the interventions of clean cool stoves and clean fuel, but very important when you're looking around reducing air pollution from cooking, behavioral change is a very, very big component because cooking is a behavior. And so in Uganda, we did a study where we introduced education around air pollution and its effects. And it was delivered by the midwives during antenatal clinic, the routine antenatal clinic health education talks. And we're basically assessing the feasibility and acceptability of the midwife health education strategy to reduce exposure to biomass smoke among pregnant women in Uganda. So this is the midwife really giving health education to the mothers attending antenatal clinic. And we used education materials that we developed and were approved by the Ministry of Health. But the important thing was they had basic messages. What happens, what is air pollution? What is biomass smoke? What happens when you're exposed to biomass smoke? What happens to your baby when the baby is still inside and when the baby is born? And what we are looking for, 2 things. Were the mothers able to actually retain the knowledge they had received during the antenatal clinic attendance? But very important, would that knowledge help them to make some changes or to have an intention to make some changes in order to be able to reduce air pollution exposure? And what we found that was that there was improvement in the knowledge of the women, much as they really didn't have a lot of knowledge around biomass and its impact. By the time of the education session and 3 months later, they still had that knowledge, and they even started making some changes. And some of the changes which they could make, they no longer stayed within the kitchen while cooking all the time. They tried to move away from the kitchens. They no longer put their babies in the kitchens all the time. Instead of burning refuse within the compound, they started burying it so that it could be used as manure. And very important, they had intent to make some changes within their household. For example, improve on the ventilation, probably buy solar or get a cleaner cook stove. But one of the key issues which were really prevented them from doing so was the issue of poverty. And so we find that in many communities, poverty is a major barrier to actually using some of these interventions. I'll briefly touch the policy initiatives. There have been different policy initiatives in different countries. For example, in UK, they looked at the fuel quality and they set up standards and it is being implemented. And they've had a national campaign to actually encourage its uptake. In South Africa, they've encouraged investment in renewable energy sources, and they're offering tax allowances and deductions to those who are able to invest in that. In Namibia, there was a public campaign on forest conservation, and this really led to a reduction in the burning of the forests, and therefore eventually reducing on the air pollution, the ambient air pollution. In Rwanda, they've banned the non-biodegradable plastic bags. When these bags are really burnt, they give off very noxious agents. So the banning of these non-biodegradable plastic bags has actually led to the reduction in the air pollution. What is not clear is whether these policy initiatives actually translate into the reduction in air pollutants that are significant enough to lead to better lung health, both for the children, but also for the adults. I think as the policy initiatives are being introduced, we need to concurrently carry out research and find out if they're actually making any impact on the lung health of the children. Other things that have been proposed by scholars is the issue of urban planning. We know many of our cities, especially in Africa, the planning is really poor, but in terms of urban planning, we should try and find gazetted areas for industries so that helps reduce exposure. Some structural designs and operations that minimize emissions. Also to provide ways where people can have active transport. On most of our roads, even if you wanted to use a bicycle, there is nowhere you can actually ride it safely. But at personal level, you can limit physical exertion outdoors where on high pollution days. You can minimize use of highly polluted areas. You can identify and don't use that road on that day. But very important, if we can develop air quality alert systems, the way we read the weather and know that it's going to be rainy and then you carry the umbrella, I think we should find ways of actually having this air quality data to give us alerts, and then we can act appropriately. So I want to highlight some of the gaps in research and the opportunities that exist. Number one, this question was raised before, but we still ask. If you look at most of the researches, there was no really benefit in terms of improving lung health. So we are wondering, how clean does the air need to get for us to see the health benefits? But we also need some cohort studies in Africa that can document the impact of sustained air pollution, and then to see how this correlates with lung health. I think we need rigorous and really methodologically strong studies with clear underlying behavioral theories and practices. Most of the studies where we didn't have an impact, the reasons around behavior change, where there is stove stacking, where they want to use certain stoves for different foods, where there are power relations within the household and so forth. So I think a strong use of behavioral theories and practices when we are introducing these interventions is going to be very helpful. But very important, we need to evaluate the early life origins of disease in relation to biomass smoke exposures, both in infants and also in early childhood. And where we have the government-led initiatives in air quality monitoring, air quality management, we need to be able to find out how these impact on lung health outcomes. So I want to share some of the initiatives that have been already started in this line. In terms of behavioral change, the Happin study did affirmative research before they did the trial, and they noted some key findings. One, the perceived disadvantage of solid fuel use actually helps people to use the clean cook stoves. If they find that solid fuel use really is, they understand the disadvantage, then it's easier for them to adopt the clean cook stoves. Family influences on cooking decisions, the heating needs. You may give the LPG, but if they have heating needs, for example, in the highlands, then they'll go and use their dung to provide heating. The previous awareness and experience of LPG really helps them to adopt to use of LPG. People have fears around LPG that we shall have burns and so forth and accidents. So if there is previous awareness, actually helps to uptake LPG. The traditional cookware and stoves used in the cooking, as well as the traditional foods and preferred stove for preparing them. So all these things have to be put into context when we are really initiating this intervention so that their uptake is improved. I want to share one of the studies that we are doing in Uganda. We are trying to address primary prevention. And in this study, we have enrolled pregnant women at around the first and second trimester. And what we do, we monitor air pollution exposures. We do carbon monoxide monitoring, the personal carbon monoxide monitoring for a period of 7 days. We do the PM 2.5 monitoring within the household for 24 hours, but we also do community air quality monitoring for a month. And what we are trying to see is to see how these different environments impact on the air pollution exposures during pregnancy and how this impacts on the lung function at birth. And we think that this can help us really find the information that can help in the interventions in this rural community. But very important is that in this particular study, we are also doing the nutrition of the mothers, checking if it impacts on the lung function and the socioeconomic status. One of the reasons we think we are not getting a breakthrough in improving the lung health of the children is you are considering single factors, and yet we have to look at all the factors that potentially determine the lung function of the children and therefore the risk of lung diseases later on in totality. So we hope that this study, which is really looking at multiple factors, can help us set a ground for effective interventions to improve lung health in children. And then for the older children, I mentioned earlier that we have issues around data, real-time data, and how to correlate that air pollution data with the lung function or the lung diseases in children. Again, in Uganda and other 6 countries in Africa, we are doing what we call the children's air pollution profile. So what we are doing, we are looking at school children and we are profiling their air pollution exposures at home, during commute to school and from school, as well as the school environment. And we want to find out if we are to intervene and reduce the air pollution exposures in these school-going children, where do we target most? Is it at home? Is it during transit? Or is it at school? And we think this will actually provide some information that can actually help us intervene appropriately and subsequently improve the lung function in these children. So in conclusion, I want to say that interventions to reduce air pollution have been tried in many places. Some of them have helped to improve children's lung health, but I think we still need a lot of work to do, especially in research. And some of the areas that I propose, we'll need to look at technologies. We need to have low-cost designs that are acceptable and sustainable. We need to incorporate behavioral change in the studies on air pollution. We need to look at policies and not just to introduce policies, but to monitor closely how these policies actually translate into better lung health for the children. But we also have to put a lot of emphasis on affordability, access to the desired stoves and the fuels, how these stoves can be maintained, as well as the lifespan, because these issues actually influence the uptake and sustainability of stove use. And lastly, we need to consider in-depth evaluations to provide insight into the fidelity, the feasibility, and other things around implementation of these studies, and as well as the causal mechanism. I think if we take a critical look on how these things are being done, maybe we might be able to unearth where the gaps are and address them in subsequent research studies. I want to thank you so much for listening to me, and now I'll hand over back to the chair. Thank you.
Thank you very much, Rebecca. That was an excellent talk and a nice overview for all the interventions possible. So we'll now go to the questions. There are some questions in the Q&A, but I would like to start off myself. What I think is a very nice project is your project with the midwives, because what I personally think is that awareness is very important as a first step. What I noticed even here in Rotterdam, but I think everywhere, is that people are not aware what they are breathing and what the health effects are, and then are not able to adjust their habits. So well, that's a compliment. And do you have other ideas about how to create awareness? And that's also a question for Jakob, of course, how we can create more awareness amongst people so they can adjust their behavior.
who should start? So thank you very much for this idea. I totally agree that this is maybe most of the important challenges. When I moved to Switzerland, I always thought that the air is clean here. That's why I moved here. And now I realized, even though I live kind of in the mountains, it's not clean. And I mean, was also to me a kind of being aware that actually the air which surrounds us, even though the WHO said you're living in the clean air area, still has an impact. I think this is, as a researcher, very difficult to do, but it has to go through the politics because otherwise this cannot be implemented on a larger scale. So my personal thinking is that only on a larger scale you can really address and do changes if this is really appreciated by the politics. And there I see, at least in Europe, a major problem. Also speaking about Germany, large car industry, a rich country where so much more could have been done, but available research is not just appreciated because other factors such as industry is just much more important. So I see the major challenges in convincing the politics to actually implement measures.
Okay, thank you. So there are some questions, I think. My co-chair has a question for Rebecca.
I think we could probably move on to some of the questions from the participants. There's quite a few questions that have been put up on the Q&A, and then we can take discussion on this. So there's a question by Kuku Voi, and I think this probably is for Rebecca. The studies in Malawi and Guatemala consider the influence of ambient air pollution. And then Kuku goes on further to ask, what suggestions do you have regarding the importation of older cars from developed countries that may be polluting the air? Rebecca?
Okay. Thank you for the questions. The study in Guatemala was done in the highlands, and what they noted that the homes are really sparsely populated. They're very sparse, very apart, and they don't seem to have a lot of outdoor air pollution, not from the cars, not from the roads. It's usually from the indoor, the cooking. So they thought if they only intervened in the indoor, then they would have probably better results, but it didn't happen. For the Malawi study, of course, there was a lot of, there was some degree of burning of the outside, the burning of the refuse, the bushes, and they think one of the reasons they think there was no impact is because of the influence from the outdoor air pollutants. So again, I go to the point of looking at the different spaces where children are exposed so that when we are intervening in totality. The issue of importation of old cars, I know there are some countries, including my neighbors in Kenya here, that have banned importation of old cars. And of course, that helps in reduction of the air pollution from the transport, especially for the urban children. The question I have, and I think which we should do, as we start and implementing these policies, we should first of all see how the policies are being implemented, if they are being implemented effectively. But if the air pollution is reduced to a level which improves lung health. In all these studies for the cook stoves, there's evidence that the air pollution has been reduced by the intervention, but this hasn't translated into better health. So we need, as we do the implementation of the policies, to also monitor the air pollution levels as well as the health impact so that we can say these policies are actually helping us. Thank you.
May I add something there from my side?
Sure, please.
Thank you very much. I was just wondering, I didn't read so much the studies in Africa and regarding the outcomes. And as I remember correct, a lot of outcomes were questionnaire based. So acute respiratory tract infections or very severe symptoms such as pneumonia. So I was wondering, perhaps there is an impact, but we just cannot observe it because sensitive outcome measures such as lung function has not been done in a lot of studies. So perhaps there is already a positive impact on these measures which are done, but the outcome measures are not so sensitive in assessing that. So putting that the other way around, if I would have done my study in Switzerland with the outcome pneumonia, I would have been sure that I would have found anything. But because we looked at lung function, very sensitive lung function test, we could find something. So perhaps there is already a positive trend in some of these measures which are done and this intervention in, for example, South Africa, but we just don't see it because the sensitive outcome measures are lacking. So I would just phrase it more positive. Maybe there is something good already, but it's just not observed with these very severe outcomes, I would consider.
I think that's a very good point. There's another question in the Q&A that maybe fits this part from Irene Najingo. She says, thank you, Dr. Nantanda, for this presentation. Are there follow studies that show the outcomes of children with poor lung function to show what is the risk of developing asthma or COPD, given that a child had poor lung function at birth? So are there long-term follow-up studies of part of the children? It's a question for Rebecca.
Yeah, thank you. There have been some cohorts in different parts of the world. We also have the South African birth cohort, where they've done lung function during infancy, and they've followed up some of those children to see whether the ones with poor lung function actually develop asthma, and the answer is yes. And particularly the one of South Africa, they looked at the risk of having repeated respiratory tract infections. So it was found out that those with low or suboptimal lung function actually have a high risk of developing lower respiratory tract infections. And we know that when you have those repeated respiratory tract infections, then you have a higher risk of developing diseases like asthma and COPD. But I think the cohorts that we are starting in Africa, the South African, there is a cohort in Ghana, and now in Uganda should help us really study the life course of the lung health at different age groups. But yes, we have evidence that poor lung function at birth translates into high risk of asthma, COPD, and other lung diseases. Thank you.
Thank you. So there's a question from Refilwe to Jakob directly. Jakob, from your talk, which interventions do you think would be best suited to reduce pollution levels, both indoor and outdoor, because of these, some of the findings that Rebecca has spoken about, which have not been conclusive? I mean, you have a different opinion that there may be important findings, but we're not just using the right outcome measures. But in terms of trying to reduce indoor and outdoor pollution, what do you think are some of the best strategies to use?
So the strategies, I think I'm not the expert, and I think Rebecca has nicely shown that I think there's a very, very high concentration indoor air pollution during cooking, and I think these interventions which have been done are massive in the decrease of air pollutants. There is the limitation, which Rebecca also pointed out in regards to resources. So in a study setting, when the gas stove is given for free, everybody uses it. But I think if families have to buy it on their own, it becomes very, very, very difficult. In regards to other outcome measures or interventions in Europe, where indoor air pollution is not such a problem, I really think that, as I said, the politics should be more strict and harsh with the industry to reduce the air pollution, the outdoor air pollution. But I think it's really a regional difference we have here. And maybe I can also ask or answer the next question in the chat, which I just observed. So there's a question whether there's an impact on the immune response in the child. And I briefly touched on this in my presentation. And yes, there is a negative impact. This has been done and reported in several studies. However, I am not aware of so many studies looking at this longitudinally. So there have been studies showing that higher air pollution level changed the immune response in the child. But at least to my knowledge, it's not so conclusive yet how these early changes translate into later problems.
Okay, by now it's past 7. And unfortunately, we have to close this session, although we could all speak about this subject for a very long time, I think, because it's very important. But I would like to thank you all for joining this interesting meeting and on this important topic, and see you all in the next webinar, maybe, of the Pan-African Thoracic and European Respiratory Society. Thank you.